Good afternoon, everybody, and welcome to Care Connection, the free live webinar. Before we begin, I just want to let everyone know that today's presentation will be in listen-only mode. On the right-hand side, you will see the control panel. At the end of today's presentation, you could type in your questions and concerns. Again, on the right-hand side in the control panel, you will also find today's handout in PDF. Today we have a very special guest, Ashwani Rayo, and today's topic is going to be falls and home safety in Alzheimer's disease. Ashwani Rayo is an occupational therapist with doctoral and postdoctoral training in movement science. He has over 20 years of clinical experience with a focus on rehabilitation and neurological disorders. Dr. Rayo's research aims to develop quantitative and clinical methods to examine motor dysfunction in neurodegenerative disorders, understand motor control mechanisms underlying motor dysfunction in order to design and test novel rehabilitation strategies. Dr. Rayo teaches physical therapy and medical students, and we are going to begin today's presentation. Thank you, Dr. Rayo, for volunteering your time and expertise today.
Thank you so much. Everyone, welcome, and thank you for taking the time to attend this talk. As you just heard, I work at Columbia University in the program in physical therapy. Unfortunately, my office is right across the emergency department, so every once in a while we may, I hope not, but we may hear ambulances going by. So the title of my talk is Falls and Home Safety for People with Dementia. And I'm happy to represent the Center of Excellence in Alzheimer's Disease at Columbia University Medical Center. So the outline for this talk is that I'll give a brief background on gait and mobility, and again, a brief background on dementia before asking a few questions, the first of which is how common are balance and mobility problems in people with dementia? Then what balance, particularly what problems in balance and mobility are seen in dementia? And then we'll look at some of the factors that lead to falls. And finally, I'll talk about the role of physical and occupational therapists and look at what the science tells us in terms of the role of exercise in Alzheimer's and in dementia. So I'll start with a brief scenario. So I've written 3 scenarios, starting with a very simple scenario. And each of these scenarios is something that we have done almost every day. The first scenario is just imagine for a moment walking down an empty, well-lit hallway in your home. Now, for most of us, that is not challenging. We're able to walk down an empty hallway in a familiar environment. Now, imagine the second scenario. Now you're walking from the kitchen to the dining table, carrying a pot of hot food in your hand, while negotiating with throw rugs on the floor. So clearly in this scenario, we are walking, but we're holding something that is hot, and we're also trying to negotiate some things in the environment on the floor. Now, if you imagine the third scenario, that's the most complex scenario. We're walking on a busy street while carrying a cup of coffee in one hand, mobile phone in the other hand, a bag on your shoulder, and negotiating several people walking at different speeds, sometimes in different directions, people walking with their dogs. Now, if we think about each of these scenarios, they present a challenge in terms of the demand on our cognitive system. Clearly, when we think of the cognitive demand, the order of these scenarios changes. So walking on the busy street is the most demanding, and walking down an empty, well-lit hallway seems the least demanding. So I listed these scenarios as a way to appreciate that even in otherwise healthy people, there are tasks that present with complexity. In particular, when we're trying to manipulate objects in our hands, or we are in environments where we cannot predict the mobility and movement of other people. Now, imagine a person with dementia. Their cognitive demands would probably be higher even for simpler tasks because of the impairments within the cognitive system. So I'd like just to begin with just thinking about these three scenarios, that sometimes the task becomes complex because of the complexity within the task, or sometimes the complexity comes from the environment, or both. So as you all likely know, dementia is increasingly common. We hear every year in the news, particularly in the Western world, that the frequency of dementia is going up. And the most common forms of dementia include Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and Parkinson's disease dementia. And in the US, currently, there are about 5 million people diagnosed with Alzheimer's disease. So it is a challenge that is fairly common. Again, this is a background review. You all probably know that the primary problems in Alzheimer's disease are challenges with memory, challenges with what we term executive function, which includes judgment, decision-making. Equally importantly, what we are seeing is that people with Alzheimer's disease and dementia in general also have challenges with mobility. So one of the problems that we often see is that people with dementia typically reduce their speed while walking. And that reduction in speed becomes much more prominent when people are performing either a cognitive task like speaking with someone, or a manual task such as carrying something while walking. So now the second question, how common are balance and mobility problems? For people with Alzheimer's disease, about 25 to 40% report having some difficulty with balance and or mobility. That frequency is much higher for people with dementia with Lewy bodies, vascular dementia, and it is the highest for people who have Parkinson's disease with dementia. For people with dementia, the next question is how common are falls in both aging and dementia? And the Centers for Disease Control has extensive data on this, that for otherwise healthy people above the age of 65, approximately a third of them experience at least one fall in a given year. That number goes up to a little more than 50% for those who are 80 years and above. Now, when we look at the bottom of the slide, those are the prevalence or the rate of falls for people with different forms of dementia. So for Alzheimer's disease, the rate of falls is about 25 to 40%. and it is much higher for people with vascular dementia at about 80%, dementia with Lewy bodies about 75%. And when we consider dementia from all the factors, the rate of falls is about 60%. So clearly, falls are quite common in people with dementia. So what are some of the mobility and balance problems that may increase the risk for falls in people with dementia? Now, typically, if you were to go to a physical therapist and get an assessment of balance, typically we ask people to stand with their feet together. And if you look at the figure, it's the center figure on the top row where it says feet together. Then we would ask people to stand in what we call semi-tandem, where one foot is a little in front of the other. And we typically ask people to stand for a period of 10 seconds or so. And then we increase the complexity of the task and we ask people to stand in a tandem stance with one foot directly in front of the other. And then finally, we might ask them to stand on either the right foot or the left foot, so single leg stance. And when we do an assessment like this, what we see is that as we reduce the base of support, or as we narrow the support base, for example, as we go from feet together to a semi-tandem, to a tandem stance, to a standing on one foot, we see that people have greater and greater difficulty as the support base itself narrows. Again, clearly, if you ask people to stand with their feet together, with their eyes closed, balance becomes worse. In terms of mobility, perhaps the most common and simplest assessment that we do is something called the timed up and go test, where, as the figure shows, we start with a person in a seated position, and on a go signal, we ask them to get up from the chair, walk a distance of about 10 feet, turn around, walk back, and take a seat again. And we typically time people as they perform this task. Often, we also perform the same task while the person is either carrying a cup of water in their hand or while they're performing some kind of cognitive task. When we do tests like this clinically, what we typically see is that, as I mentioned before, people tend to slower their speed of walking. People tend to walk with shorter steps. Sometimes we see people shuffling. And as a compensation for the problem with balance, people spend more time on both feet and people widen their support base. Often turns are unstable, and sometimes getting up from the chair or getting up from the bed or sitting down on the chair or bed becomes challenging. Now, clearly, balance and mobility problems have a consequence. And perhaps the most important consequence is the increased risk for falls and related injuries. And as we mentioned before, the fall rates for Alzheimer's disease can be between 25 and 40%. And clearly this is very important. We all know this, that the consequence of falls can be catastrophic, so it can lead to injury. Often falls will lead to a fear of future falls. Often falls itself may lead to reduced independence in activities of daily living, and then as a consequence, reduced quality of life. Now, one of the consequences of falls that we as therapists focus on is the fear of falls. So when somebody has a fall, they become very fearful of falling. And the natural consequence of that fear of falling is to reduce their mobility, because they don't want to put themselves at risk for future falls. Now, in the short term, that might be an okay compensation. But in the long term, what that does is that reduced mobility leads to deconditioning. Deconditioning then leads to a loss of strength and balance. And then this loss of strength and balance actually increases the risk for falls even more. And so we call this the kind of negative spiral of the fear of falls. And so our job as therapists is to break this spiral when people have a fear of falls, and we teach people to not reduce their mobility, but in fact, we help with their conditioning, we help with their strength and balance so that their risk for falls does not increase further. So what are some of the factors that could lead to falls? Now, the first set of factors that I'm focusing on could be termed as intrinsic factors, so factors within the person. So as we just mentioned, reducing physical activity could itself lead to an increased risk for falls. If we have more problems with balance or mobility, if our mobility becomes limited, those difficulties also increase the risk for falls. In addition, for people who have problems with sensation, for example, if there's a problem with hearing or if there's a problem with vision, that itself could lead to an increased risk for falls. And clearly, one of the risk factors for falls that applies to all of us is age. So as we get older, our risk for falls goes up. And medications, particularly the number of medications that people might be taking, needs to be examined by the physician to assess whether they themselves may increase the risk for falls. Cognitive problems and confusion also could increase the risk for falls. Now, among all these factors, I have highlighted or bolded the top three because those are what we as therapists, both physical therapists and occupational therapists, focus our attention on. So those were the intrinsic factors that could increase the risk for falls. In addition, as we saw in the scenarios at the beginning of this talk, factors could be outside of the person. So environmental challenges could also increase the risk for falls. Examples are lighting. Poor lighting could lead to increased risk for falls. Not level ground is also a risk factor. Not having adequate space in the room, in the hallway, or in the doorway. Furniture that's not supportive. Clutter at home, or absence of grab bars, particularly in the bathroom, could increase the risk for falls. So now that we have talked about some of the mobility and balance problems that people with dementia face and the risk factors for falls, the next question is, well, what is the role of a physical therapist or an occupational therapist? So occupational therapy, they conduct an assessment of functional limitations. Often in coordination with a social worker, we conduct an assessment of home safety. Occupational therapists, or OTs, train people to improve their independence in activities of daily living and improve home safety. Physical therapists perform an assessment of balance, assessment of gait, assessment of strength, muscle strength, and they prescribe an exercise program or a program of physical activity that helps to improve strength, balance, mobility, and conditioning. So what are the recommendations in terms of occupational and physical therapy? Well, first, it helps to maintain a consistent daily schedule of activities. As you all probably know, people with dementia have a difficult time when activities or plans for activity change suddenly. So it helps to have a consistent schedule of activities. It helps to increase overall physical activity. So what do we mean by that? Well, often senior centers or physical therapy departments have group walking programs, or they may have a balance training program, or they may have individual or group exercise program to help improve balance and strength. And these exercises are helpful for people with dementia. So what does the science say? Well, a few years ago, we had published a review where we looked at a number of different studies. We found 6 studies that had administered a walking program for people with Alzheimer's disease, and also included strengthening exercises. And they found that over a long period of time, a lot of these studies were conducted over 9 months, that exercise such as walking and strengthening helped to improve independence in activities of daily living. A review paper published in the British Medical Journal looked at a number of studies and found that exercise reduces functional decline. So those people who exercise were able to maintain their functional independence for a longer period of time. And there are a couple of studies from Europe mostly that have looked at the effect of exercise not just on mobility and balance, but the role of exercise on improving cognitive skills. And they found that exercise indeed has a positive effect on cognition above and beyond the beneficial effect of aerobic exercise on mobility, balance, and strength. So in terms of the extrinsic factors, the environmental challenges, this is a cartoon where we see a number of environmental challenges, and I'll point out a few. So the first is that if you look at the stairwell, it has no railing. Second, there's some clutter on the stairwell. There are boxes on the stairwell. Third, there are throw rugs that are in the walking path. Fourth, there are wires that run across the floors. Fifth, we see that there's an animal at home. And on and on and on. So the idea with this figure is that occupational therapists and social workers come to people's homes and are able to do an environmental safety assessment to find out if there are factors within the environment that themselves lead to an increased risk for falls, because that is something that can be easily addressed most often. So what are some of the most common environmental modifications that are recommended? First is clearly that there has to be adequate lighting. We look at obstacles in the walking path. We look at floor rugs or throw rugs or mats, clutter. It's important to assess whether the furniture that people are using is stable or unstable. We look for presence of electrical cords. We look to see if there are railings on stairwells or in hallways or within the bathroom that can assist with walking and balance. And then we look to see if the furniture height is adequate and consistent. So in terms of lighting, it's useful to have bright and consistent light in all areas. Sometimes what happens is if we have a living room, one part of it may have bright light and a second part of it may have very dim lighting. That contrast itself, suddenly when you walk from either the bright light to a dim light, even for us, it makes that challenging. And when people are faced with cognitive difficulty, balance difficulty, and walking difficulty, we're actually making the task that much harder. So it helps to have bright and consistent lighting. It's important to make sure that surfaces are level and are at the same level. When there is a change in texture or when there is a change in level, for example, as you see in the figure at the step, it's important to enhance the visual contrast so that people, even with poor vision, can see that there is a step coming. And step height should be consistent from one step to another. I say this because not all places do we have consistent step height. In fact, the office building that I work in, my walk up to the third floor has steps that are completely not consistent one from the other. In addition, in the living room, as far as possible, we have found that people say that when furniture is placed close to the wall, that is helpful because that helps provide a lot of adequate space within the room for people to walk. It's helpful to reduce clutter by reducing coffee tables or side tables because those can become obstacles themselves. And as we talked about a few minutes ago, removing cords and throw rugs is very important. Again, within the bedroom, it sometimes helps to place the bed next to the wall to make more space in the middle of the room. And it is important to assess whether the bed frame itself is stable or not. Sometimes putting mattresses on the floor may be an option if the person can get up from a lower height. Once again, just like the living room, removing throw rugs and cords from the floor is important. And it's important to ensure that no small furniture is placed in the walking path. Within the bathroom, here this figure shows an idealized situation. I recognize that sometimes space is a problem in urban environments. So sometimes we have the option of installing a shower stall, but sometimes we don't. Shower stalls tend to be easier to get in and out of. And even if we don't have a shower stall, often it's very helpful to have grab bars that we see on the walls here. It's very helpful to have a shower bench or a shower chair so that the person doesn't feel more imbalanced when they're taking a shower. Again, it's very helpful, as I mentioned, to have a shower bench or chair. Often, when people still are maintaining their independence in showering activities, it may be useful to have a handheld shower and a soap attached to a string so that it doesn't fall. And we talked about this before, that having safety bars within the tub and just outside the tub is very important because that helps people get in and out of the tub safely. So to wrap up, what we've talked about is that even though dementia and Alzheimer's disease is a disorder that is known for difficulty with cognition and executive function. Balance and problems in mobility are quite common in people with dementia, and that these balance and mobility problems result in an increased risk for falls and can reduce independence in activities of daily living. Exercise is helpful in maintaining functional independence, in improving strength and balance, and home safety assessment and modifications are very helpful in eliminating or at least reducing environmental hazards that themselves may contribute to an increased risk for falls. And very importantly, a consistent schedule of activity is important to prevent confusion. Now, one note about exercise prescription is that it is important to get into the habit of exercise. And so the consistent schedule of physical activity and exercise, it's important to get into it early. The earlier we get into it, the better it is. Because then we ensure that strength and balance and functional independence is maintained for a longer period of time. So here is a little more information. This is the website for the Center of Excellence in Alzheimer's disease. If you have any questions, I would encourage people to get in touch with us. Our center coordinator is Priscilla, and the number and email is listed on that website. And then there are resources that the Alzheimer's Federation has compiled in addition. For more information, the website has a lot of information on support. So I thank you very much for your attention, and at this point I'm happy to take a few questions.
So first, this was an excellent presentation. I certainly learned a lot of new information. Most of it was new to me and I'm sure our listeners, but we do have some questions waiting for you. And so what are your thoughts on teaching people to fall safely? And then how to get up from a fall? Can you give us, describe a couple examples of good balance exercises or websites with good balance exercises? So this is a two-pronged question.
Sure, that's actually a very, very good question. There have been a couple of groups in Europe. I think there was an article in the New York Times recently that there's a group that has been training older people to fall. And the idea is that if people learn how to fall, then the consequence of falls are minimized, so people don't get injured as often. So I do think that going to a physical therapist is very important because that helps to create, they will help to create a program to improve strength, to improve balance. But at the same time, I do think that training to fall has been shown there have been a couple of small studies that have shown that they help to minimize the effects of falls. Now, in terms of exercises for balance and walking, well, the simplest exercise perhaps is walking. And if you think back on where we started, we started by imagining these simple scenarios, walking in an empty hallway, walking in a hallway with things in our hand, while performing some kind of a cognitive task. And so walking, I think, is one of the most underrated exercises that we can do. And in fact, I encourage people to go out to a park because walking in an outdoor environment actually is very helpful because the ground may not be as level, so people have to pay more attention. There may be some obstacles in the path that people have to pay attention to. There may be other people in the park, and so walking in these complex environments is very, very useful. Some of the balance exercises or other exercises I tend not to recommend a lot because sometimes people try those exercises on their own. And when you're challenging your balance in a system that already has compromised balance, we don't recommend people to do them on their own. So we hope that they're done with a buddy, with a partner, a caregiver, or a therapist. But a few simple things that we recommend often is simple, again, it's a strength exercise. Sitting in a chair, you start by sitting in a chair and you get up without using your hands for support. And you do this 5 times. Or as you get better, you do it 10 times. And then you take a break. And then a couple of hours later, you repeat this. So if you do this simple sit to stand exercise, you'll notice that your strength in the muscles of the lower limb improve. A second simple exercise is to stand on your toes or to stand on your heels. And again, the goal is to be able to try and stand for a period of 10 seconds. But as I mentioned, it is important to do these exercises with supervision or with the help of a caregiver.
Thank you. We have some more questions waiting for you. Another question is, any relationship where wobbly feet is an early warning for dementia?
Mm. Again, a very, very good question. It may be, we are not sure yet. In fact, we're conducting a study right now where we're looking at some of the early markers, both sensory markers, but also in terms of mobility. We have seen there has been some work showing that in mild cognitive impairment, which is often seen as a precursor to Alzheimer's disease, there are some characteristic changes in walking. And so one of the things that I mentioned in my talk was that when there is more inconsistency in our stepping, that may be a sign of Alzheimer's risk. And so that has been shown. And also the reduction in speed as someone is performing a cognitive task while walking may also be a marker. So indeed, there is some evidence, but there are studies that are going on to improve our prediction of that.
Thank you. And the person who asked a question would like you to share the publication of this, if you can, the study.
So sure. So there are a couple of papers that I referenced. I'm happy to share the paper that we had authored on the role of exercise. Absolutely, I can send that along to you, and you can share it. A couple of the other papers, as long as they're accessible publicly, I'm happy to share those.
Thank you.
Yeah.
Okay, we have another question.
Mm-hmm.
You mentioned an option of placing the mattress on the floor.
Mm-hmm.
What is the benefit of this?
So sometimes, if furniture is unstable, or if the bed frame itself becomes an obstacle, then people sometimes find it easier to get up from a mattress or to sit on a mattress. Now, for a lot of people, that may not be an issue, but I'm just basing this on some of the people that I've spoken to, and some people do see that there's a benefit to it. So it depends on if it works for the person. So that's why we don't recommend it to everyone.
Thank you. Another question is, can electrical stimulation of feet nerves help?
Good question. I don't believe that this has been studied, so I don't think there's any evidence to suggest that. Certainly, if we provide some stimulation on the feet, that may help improve the sensation, which may indirectly help improve balance and mobility. However, I would caution people that right now there is no evidence to suggest that it is helpful.
Thank you. Another question. Is there benefit from the standing and sitting exercise if you use your hands to stand? I ask this because my residents do this exercise, but they use their hands to stand.
Mhm. So the simple answer is yes, it's helpful. And the reason is that people are changing their position, people are still using their muscles in the lower limb. However, if they're bearing a lot of weight on their arms, then they're using the muscles in the legs less. So if they have been doing this exercise and they've been using their hands for support, the question is, can we see if that support can decrease over time, over a period of a few weeks? If so, then we know that yes, the strength in the lower limbs is improving.
Thank you. I have another question. What about if you have a resident who is non-compliant with their durable medical equipment and that increases their fall risk? How do you help someone who's non-compliant?
That is a challenge. That is a challenging situation. Um, if someone needs a walker, and it helps them to maintain their balance, and if they're just not using it, um, often the solution to that is one, reducing the environmental obstacles or hazards, two, maintaining a clear, consistent schedule of activities, three, increasing the supervision, which sometimes is very difficult. And if there are railings in the hallway, perhaps encouraging them to walk close to the railing so that they can reach out and hold on to it if they need it for support.
Thank you. We
Mhm.
we are still taking questions or comments, um, so keep them coming. We have a we have a good amount of time left. Someone wrote, I know that there's a correlation between some medication side effects and falls. How can we work with the pharmacist to um, to lessen the falls with the medication someone's taken?
Mm, that's a very important question. I think the person to speak with is the neurologist or the primary care physician who is coordinating all the medications. Um, because we sometimes don't appreciate that some medications may interact with other medications, or that some medications by themselves may increase the risk for falls. So I think the neurologist, in a lot of cases, they are the ones prescribing medications, or the primary care physician. Those are the people to have that conversation with.
Thank
And,
you.
and I just want to add one thing. Sometimes, we when we go from one physician to the next, sometimes we ourselves forget to tell them what other medications we may be on that they're not prescribing us per se, but it may be important for them to know.
Thank you.
Mhm.
Um, we have a lot more questions coming in. So hold on one second.
Uh-huh.
We recently received a diagnosis of vascular dementia in early stages of Alzheimer's. Is this important in regard to the recommendations of exercise?
Um, I don't know if the recommendations for exercise will change. I do think that it is important early on to see a physical therapist, because it may be important to improve strength, to improve balance, to improve aerobic capacity, to maintain functional mobility for as long as possible, and to get in touch with an occupational therapist or to speak with the social worker to arrange a home safety assessment or an environmental safety assessment.
Thank you. What
Mhm.
are some interventions for someone that is no longer standing or ambulating, attempting to get out of bed or chair independently, yet has no safety awareness?
Mm. So that is again a very good question. So for people who are not very mobile, often you have these exercise bicycles, and sometimes in the hospital we have these little bicycle pedals that sit on the floor so the person can sit on the bed and pedal their lower limbs. The idea is to help improve circulation, improve strength in the legs. And even for people who are not very mobile, that can be possible.
Thank you. Do you know of any studies that are being done in regards to dementia and falls during hospitalizations, specifically dealing with hospital delirium?
Mm. Um, I'm not aware of any study currently, but what I can do is I can look for studies that have been completed recently, and I can send that information, whatever information I find, I can send that along to you.
Perfect. We do have another question.
Mhm.
Are walkers with wheels and handbrakes safe? I don't trust my father with his.
Mm. So it's a complicated response. So it depends. Walkers are useful as a support for walking. Certainly, walkers with wheels are useful because they approximate our healthy walking better than the walkers without wheels. However, that said, um, for people who have difficulty with attention, or people who have difficulty with doing two things at once, having a wheeled walker sometimes is too distracting because they need to pay attention to where they're standing in relation to the walker, or when to apply the brakes, um, and to apply the brakes every time they stop. So those become challenges, and I think the recommendation that I would make is to seek the counsel of a physical therapist, because they would be able to do an assessment and prescribe a walker that is best suited for this person's father. So in general, yes, walkers are useful. It depends on the person's cognitive ability. Sometimes people are more willful than others, and if so, then I would worry about a wheeled walker because that may increase the risk for falls.
Okay. Would you recommend a fall button to a late stage with someone who's living with late stage dementia who has issues with executive functioning? If not, is there any other device you would recommend for the patient with late stage dementia?
Yeah, I think the life alert sensors, there are now that this technology has improved a lot in the last 10 years. So a lot of this technology uses accelerometers. Those are devices that are on our phones and smartwatches, etc. And so anytime there's a sudden change, that signals a fall, and that immediately sends that information to their hotline. So those are things that often we recommend for people, because just having a button sometimes there may be perseverative behavior, and so people might just push the button just because they see it, and that may not be helpful.
Thank you. Do you recommend that a person who walks with a two-wheeled walker to utilize a grocery cart when they are shopping? It seems that the cart has four wheels and could quickly be a runaway train. Is the walker safer than the grocery cart?
Hmm. That is a good question. So the grocery cart, because it's bigger, it tends to be heavier. And so it's not so easy to have the grocery cart run away. So sometimes the slightly heavier walkers are more useful to provide more stability. That said, if if there is an increased risk for falls because people are not paying attention to walking with the walker, and they're walking too far away from the walker, and if they're not able to control the speed of the walker, then I would recommend thinking about a two-wheeled walker as opposed to a four-wheeled walker. Um, but in general, the weight of the walker is important. So if it's a little heavier, that might help. In fact, there are a few walkers in the market where you can increase the resistance of the wheels so that they don't roll quite so easily.
Thank you. If one is comfortable taking large strides, is it better to shorten strides before signs of a fall?
It's a good question. Often when there is imbalance, our system automatically compensates by reducing the size of the length of the stride. I think it is important in training, one of the things we focus on is improving strength, improving balance, improving walking speed. And when we improve our walking speed, naturally the length of our stride goes up a little bit. But if someone has large walking stride, but they also have imbalance, in that condition, I would recommend reducing the length of the stride to compensate for the imbalance.
Okay, we have time for about two more questions. I don't want to seem redundant with this issue, but the biggest problem is to get some residents involved with activities. Do you have a wow factor idea you heard of that can get them involved in a walking club?
Hmm. I mean, which is why I think the earlier these activities start, the better. It's very difficult to create a change in an already established schedule of activities. So when people come to the facility, I think that's the time to start. A second thing is that in a number of the studies that we read, they found that if the walking program, if the place that they're walking is pretty, if you will, then more people are encouraged to walk. Sometimes, if they see some people walking every day at the same time, they're more encouraged to join in that activity. So those are
Thank
some
you.
of the strategies we have seen that work.
Those sound like good strategies. Another question is cognitive behavior change in walk. If the person's walking, will their cognitive behavior change?
So what we do know is that aerobic exercise, which helps increase the blood flow in the brain, it's aerobic exercise that results in change in cognitive function. So if it is walking at a comfortable speed for a short period of time, that by itself may not improve cognition. But if someone is walking, but in addition to that is doing 20 to 30 minutes of an exercise stationary bicycle, um, then that may actually help encourage or improve cognition.
Do you recommend any type of shoe for the person who's living with dementia and walking? Is there a specific shoe that you recommend?
Very good question. So what I do recommend is one, shoes that are comfortable, by which I mean that there's enough padding. Um, Shoes that have a Velcro strap so that it's easy to take on and off. Shoes that have support on the heel. So often we tell people not to wear flip-flops or sandals because those don't provide stability. And shoes that are flexible on top. I think sneakers are ideal.
Thank you. We have one more question.
Sure.
The biggest problem for me is getting a person back up after they have fallen.
Hmm.
The fallen person just wants to rush getting back up, not pausing for a quick assessment and grabbing at unstable things to help prop them up.
Mhm.
It sounds like a statement, but maybe you have some insight on this.
Right. No, I think that that's important. We did
Yeah,
talk about it a little bit. I
exactly.
do think that sometimes, I mean, it's very destabilizing and it can be scary for a person who is going through a fall. And the natural response is to reach out and grab anything that you see. At that time, we're not attending to whether that is stable or not. And I do think that's where the question that we had discussed earlier, the training to fall, comes in handy so that people then know not to panic. Um, Secondly, I think it is important if somebody has fallen and is on the ground, it is important to do a quick assessment um, before they attempt to get up. And again, um, familiarity with the caregivers is extremely important. If there's somebody new and they're telling you not to get up when your instinct is telling you to get up, that makes it more challenging. The more familiar the environment, the better it is. So I think we have to use many different strategies to help with how to manage people falling and the response to that falling.
So it seems like we are at the end of the presentation. We had some excellent questions. I just can't thank you enough, Dr. Rayo, for volunteering your time and volunteering your expertise. We have so many people typing in right now how wonderful today's presentation was. I truly can't thank you enough. And I believe education for the community is so important, and that's why we have these Care Connection webinars. I just want to remind everyone that the handout and specifically the PDF form of this PowerPoint is on the right hand side under handout, so you guys could have it as a reference and education. I want to thank everyone for joining us, and please come back next month for our next Care Connection webinar. And again, Dr. Ayo, thank you so much for your time,
Absolutely.
and
You're
thank
most
you.
welcome. Thank you for organizing, and thank you to all the people who took the time to attend and ask all the wonderful questions. I think the more we are armed with knowledge, the better we can help people with dementia.
And I hope everyone has a good rest of the day, and we will be all keeping in touch. Thank you so much, Dr. Ayo. Speak to you soon.
Most welcome. Thank you. Bye-bye.
Bye bye.